Hello, everyone. My name is Valentina. I'm project manager at the Reference Network for Rare Kidney Diseases, which is coordinated by Professor Franz Schaefer, and we are actively involved in the JARDIN data management work package, where we focus on improving data management integration between national health systems and ERNs. And together with my colleagues from Radboud, here today it's Ines and Daniela, who will also present. And we were analyzing the current data management practices and identified barriers and also explored potential solutions. And yes, before we begin, I would like to express my gratitude to all of you who contributed in filling in the surveys. And this was really, really helpful, and your input is also strongly impacting our future tasks, where we are planning and implement and test pilot solutions in an agile manner. So today, I'm happy to guide you through today's session, and after a brief introduction and the objectives, we will touch on the methodology and the participation in the survey, and then we dive deeper into the survey results, and we'll touch on the primary data capture, the data flow, the registries, and the data sharing part. And then we will also learn a bit on data fairness by assessor, and then we hopefully also have a discussion. So the objectives of this webinar are actually threefold. So first, we will present you the survey results from the hospital data management. Then we also want to hear your feedback and collect additional information by using Mentimeter, and therefore we really hope that you actively participate in this so that we really have an interactive webinar here. Coming to the survey methods, our goal was to assess the current data management practices and identify the barriers and explore possible solutions. And to achieve this, we developed a questionnaire in collaboration with stakeholders involved in our Work Package 8 team. And in total, we designed 4 different questionnaires, one at the national level, a second one to the ERN registry managers, and actually 2 to the hospital level. And this is where we want to focus on today. And the one survey was addressed to the clinicians who are actively using the data, and the second one was addressed to the IT experts and data stewards who are responsible for managing the data infrastructure. Our survey reached 457 clinicians across almost all European countries. So actually, we are only lacking Malta. And from the IT, we got 91 responses from 91 hospitals. Although we had a bit hope for a broader reach, and particular from the East European perspectives, which we are a bit missing. But in total, when we compare our responses to the registered ERN hosting sites listed by DG Santé, we found that in most countries, over 40% of the sites have participated. However, Croatia, Poland, and Romania were significantly lower. The map here shows also the ERN hosting sites, ERN hosting hospitals of each country, also with the color-coded percentages indicating how many hospitals per country has responded. And this combines the answers from clinicians and IT experts. So, and now we come to our first Menti session, and we would like to know who is out there. And for this, I would like to that you participate in this Menti, and I will share the Menti link also in the chat. And you can also scan the QR code or access the code here. Oh, I see. We also got responses. So we see Belgium, Germany, France, Italy, also some Scandinavian countries. It says, please enter the country, not the city. It's very helpful. We also got someone from the United States. Also, Ireland is represented. That's great to see that we have so many people from different countries here today. So people are still responding. So we have a lot of people from Italy again, as in the survey as well. We also had many respondents from Italy. So okay. Then I would also like to know what is your professional background. So I know from the registration that we have many clinicians, but also some data stewards or IT experts, but also a couple of project managers. And yes, we see it again. It's the majority are clinicians, but yeah, we see also many project managers and administrative staff. Only few data stewards or IT experts. Let's wait a bit. Hey, we got 2 more IT experts, which is great. And yeah, 34 clinicians or people with medical background, which is also great, but a very huge proportion also of project managers and administrative staff. Okay, so thank you for participating. Now we will come to the first survey results part, and we are starting at the point when clinicians see the RD patient and capture the primary patient data. And here we will look at the methods that are used to capture the patient data. We also asked about the electronic health records and coding standards and the challenges you face when entering data, or clinicians face when entering data of RD patients. And the first question we asked was how patient information is initially recorded in your institution. And we provided 3 response options. And the first one was a fully digital format or in digital format, which is now here depicted in green. Then we have a combination of digital and paper format in blue and paper format only in pink. The numbers in the brackets behind each country indicates the total number of respondents. And while the sample size varies, it provides still an insightful snapshot of the digitalization levels. And we see that most countries are not fully digitalized, with a mix of digital and paper records being the most common. And this highlights the challenges of data accessibility, manual data transfer, and also error-prone processes. Next, we asked about which electronic health record system are used in the institution to clarify what is an electronic health record system. It's either a combination of hardware and software or software only, and it allows the storage, intermediation, export, import, conversation, editing, or viewing of priority categories of electronic health data. So, for example, it is not just an imaging software. So the question turned out to be quite more complex than we thought in the beginning. And we initially provided a list of 10 commonly known systems, but actually we received over 70 different EHR systems from 158 hospitals. So some of the most frequently reported system brands were SAP, Daedalus, CGM, Clininet, Epic, and Chipsoft HIX. Then we further analyzed how many EHR systems were reported per country, and the data shows high system diversity within most countries, though a few countries seem to have agreed on a unified approach, like the Netherlands, Poland, Portugal, which just use a few systems. And this fragmentation poses a significant challenge, reinforcing the need for either system harmonization or interoperable system-independent solutions. So to sum the barriers here up, we found a lack of digitalization and the fragmentation of EHR systems. Next, we explored which coding standards are used for clinical, diagnostic, genomic, and lab data. And we found that ICD-10 is used by 70% of respondents. Offer codes are used by 56%. ICD-11 adoption remains rather low, and SNOMED CT is used by only 20%. And given that offer codes are the key standard for rare diseases, their relatively low adoption rate was kind of surprising. And even in countries where we know that offer codes are mandated, the full implementation remains inconsistent. And this could be due to a lack maybe of awareness of coding practices, but also maybe a misunderstanding of the question. But if we see the result as it is, offer codes are not sufficiently implemented. Now, when we look at participants, when we look what challenges the clinicians encounter regarding entering RD patient data into EHR system, they reported that they have difficulties in capturing detailed and complex patient information, that there's a lack of possibilities to label RD data, and a lack of electronic health record templates or entry forms. And these challenges highlight the need for improved data entry structures and better RD-specific electronic health record functionalities. So to sum these barriers up, as we saw, there are lack of digitalization, heterogeneous systems, which highlight the need for system-independent solutions. There's a lack of awareness of coding practices, and current electronic health record systems lack possibilities to report and label RD cases sufficiently. And potential solutions for this, why is it just not working? Would be to raise awareness and train on coding standards, the implementation of offer codes, increase structured data capture, and on the long term, also the European health data space, which has a regulation established for electronic health record systems to standardize their components. And here we really need to advocate for requirements that capture RD relevant data elements. And people in. And now I would again like to switch to the Mentimeter session. I hope you're still there, and we are coming here to the next question. And here I would like to get your feedback. How severe do you rate the following barriers to primary data capture? Okay, you rate them all very high. That's interesting. Okay, but only 3 people that have yet responded. So the last barrier, lack of possibilities to report and label RD cases, seems to be the most severe barrier for now, but the others are also very high with 3.6. So let's wait. Okay, so we got 60 responses. Then is there one else coming? No. Then maybe let's move on. And now we would also ask you again the same question that we had in the survey, just also to see if we are in the wrong direction or if this also represent what we found out in the survey. And it's kind of similar, although the paper format here is completely lacking. But yeah, I think it's a similar result that we also got out in the survey. So next question, also we would like to know if you're using author codes in your institution. And we see that the 33 have responded with yes, while 19, 20 are saying no. It's also a bit similar than what we've observed in our survey. However, we of course I know that we also have some people here that are maybe more in the project management or administrative area. So we have to see who responded here and if they are actively working on or with health data. Okay, so we will move on to the next topic, which will be the data flow and will be presented by Ines.
Okay. Yeah, as Valentina explained, we divided the survey into different topics. We first wanted to see how data is captured in the first place. And then on the data flow section of the survey, we try to understand what is the journey that data passes from the moment it's first captured to the moment where it's shared with, in this case, a European reference network. So we wanted to see three aspects. The first one being what are the systems that are in place that store and manage the data that it's collected from patients. We offered the option to select three of these systems, the first one being EDC system, which we categorized as a sort of tool that collects clinical data in an electronic format, usually for the purpose of clinical studies or trials. We see that 50% reported the use of these systems. Then we asked if there are hospital data management systems in place, and we define this as, for instance, a hospital data warehouse where different types of data are stored for the purposes of healthcare. It can be patient data, but also information about providers, processes, etc. And we see that this was reported to be used by 70% of the respondents. And finally, we asked if there was a sort of structured way of collecting data from different data sources on national level. And we see also that this was reported as a data station for about 50% of them. So knowing these systems, the next question was to understand, you can pass, yeah. The next question was to understand how are these pathways connected? So how does the data travel to? So the arrows are represented in different thickness. Some of them it's not really easy to see, but the ones with the thickest, the ones that are thickest means that they were more reported. So we see that from EHR to Station B, Hospital Data Management, this is a commonly reported pathway, while from National Data System Collections with the C towards European reference networks, this doesn't happen as often or wasn't reported to happen as often. On the circles, we try to also see how does this flow happen? Is it fully automated or does it require some sort of human intervention? That can be either by manually entry data, or it can also be via a download, upload function or a push command, for instance. And we see that for the purpose of reusing this data, for instance, for data stations A, C, and ERN registries, most of these procedures happen and rely on some sort of human intervention. This is, again, an issue when we know that it's can conflict with data quality, also with updating of historical data, and makes a burden on hospitals because this we're only accounting for ERN registries, but we assume there's more sharing that it's necessary to happen with other systems of patient data. The third aspect that we tried to monitor was how the use of different standards and tools to structure data were used across different systems. We see that on EHRs there is, in general, higher utilization of coding standards to codify diseases, like we saw in the first presentation. But then on the following stations of this data flow, there is a drop in usage. This is also a barrier in the sense that when data is structured and uses common vocabularies, it becomes easier to extract data and to share it and to integrate it with other hospitals nationally, but also other hospitals across Europe. So the summary of these barriers are related to the fact that there's low automation of data transferring processes between different data systems. The architecture and the flow of data might be not fully clear to hospitals or people that have to provide and share data with other for research purposes. And the heterogeneous use of the vocabularies, like we saw on the last slide, make a risk to promoting and ensuring the automation of data transfer. We looked forward for solutions, so it is known to us that the European Health Data Space is already implementing some projects like the Expand, which they are working on automated extraction of EHR data. They also have the advantage of already developing some policy and guidelines that are promoting harmonization of data flows, but we still emphasize that this needs to be also done in order for local hospitals to know how should they harmonize and what coding standards should they use and what data models are advised to use. Training healthcare professionals is also necessary about what is the current data architecture in their local hospitals, but also about coding standards. We hope that by the end of this webinar, with the little example that we prepared, this is one of the things that will raise awareness also in that sense. I think now we can pass to the Mentimeter once again. again, similar like to the first section, we ask how do you rate these barriers? I see that low automation of these processes scores the highest for now. And I think also it makes sense. There's a lot of infrastructures and it's hard to maintain a good workflow when there's a lot of human involvement in all of them. And also the coding standards is the second highest. Okay. Still, both of the barriers quite high. We then ask a similar question to the one we asked above, or on our survey, where we ask which systems does patient data flow and before it reaches the ERN registry. It's also multiple choice, so you can select multiple stations. And I think it's mirroring very well also the conclusions that we got, that it feels like there's a big part of this data that passes through a hospital data warehouse. And then in some cases, it might pass also by an EDC system or a national registry. In this pool, it seems also there's more responses with mentioning national registries, a bit more than EDC. We were also wondering if we didn't account for any data station that is in between of this process of transferring data. So we are opening a free text option to hear more, to hear what other stations we didn't account for. Yeah. Yes. We also saw that there's a lot of, from the survey results, it was mostly a manual process, the inserting data into the registries. I see also Caster. And yeah, a lot of manual labor is necessary in order to transfer data to ERNs. That's also what we hear and concluded from the survey. Manual input from paper. Yeah. Yeah, I also see like a question mark. If it's a question to the presentation, you can also put it in the chat. If it's a question regarding knowing which stations it goes to, it's one of the barriers that we also mentioned, that it's not always certain which stations does data flow into and what are the most efficient ways to extract and access this data. We also have a few more questions about that in the next slide. I think we can maybe pass to the next one. Oh, there's still one question missing, I think. Sorry. So yeah, to wrap up, we wanted to know what you think about these statements. The first one regarding if you find it easy to locate specific patient data, and if you find it easy once you find this patient data and legal barriers are resolved, if it's easy to access and extract data. And I see that a lot of people say it's not totally easy to find specific data about patients, and also that the process of accessing and extracting this data is not that easy. Most of the statements tend more to neutral, I would say. Okay. I think for this part is done.
Okay, great. Thank you, Ines. Then we will move on with the rare disease registry part. Yeah. Okay, so for the registries, we are looking into the contribution to rare disease registries in ERN hosting hospitals, the challenges and the workload for registry operations. So the first question we asked were, do you contribute, or does your unit contribute to one or several rare disease registries? And we got a response that 80% of the 457 respondents responded with yes. And but there were 14% that responded with no. And for those who responded with yes, we saw that 70% participated in ERN registries, 67% participated in national registries, and around 50% in international disease-specific registries. So, which highlights really the importance of these ERN registries. And when we're looking at the respondents who responded no, and the reasons why they do not contribute to RD registries, it was mainly legal barriers, also budget staff constraints, and also to 38-degree technical difficulties in integrating the local system with the registry system. and also 11% answered that they are not aware of the relevant registries. And when we are looking at the challenges that are encountered when entering data into registries, regardless of the type, there are primary limited resources, difficulties integrating data from electronic health record systems, and also the structure of source data deviates from the registry requirements. They also reported that there are difficulties with the administrative approvals and also to balance data sharing with patient privacy rights. And also to 22%, there's also around 20%, there's a lack of training, but also there are around 8 or 10% that said there's no major challenges, which is also good news. And when we now look at the workload of the registry operations, we see that data is mostly entered irregularly on demand, which means this is not done on a routine basis. And if we are looking at the different ERN registries, what is the workload for this? We see that it's on average 10 hours per month, which means like 2.5 hours per week. So if we now put the barriers, we see that there are legal barriers for registry participation. There's also limited resources for registry operations and lack of automations. And as potential solutions, we see that if there would be an ERN legal advisor for registry operation, this could improve the situation. Also, an option for staff sharing for registry entries within one hospital could help. Also, actually, when you look at the time, there's only moderate staff time required, so 10 hours per month per registry is actually not so much time. So if there could be found efficient solutions to improve or to do this work, I think it would help a lot. And also to provide central or local support for manual entries by the ERNs or national authorities or the hospital could help here. But long term, also to improve the digital solutions, harmonize the systems and promote automated data transfer will improve the situation and reduce the resource burden. And now here we can come to the Mentimeter. And here I also would like to ask how severe you would rate the following barriers. So we have one question in the chat, which is asking, it would be interesting to see the geographical distribution of these answers. Maybe you can also tell us for which question exactly.
It was for the data flow, I think.
And yes, and I also agree to the other statement from about the 10 hours per month. Yes, it's a lot of time if it's done unpaid, but that was not how I meant it. It's also if you see like 2 hours or 2.5 hours per week, if someone could be hired, it doesn't maybe not necessarily need to be a clinician. It could be also a nurse or a student who is entering. And if this could be financially supported by the ERN, then this, I think, would improve the situation. So we see that from the Menti, the legal barriers are rated by 3.3. The lack of automation is rated with 4, which is rather high, and limited resources also with 4. Yeah, and I think for the short term, if we improve, like if we improve the manual data entry by supporting it financially and with efficient methods like sharing stuff, this would help a lot here. But long term, the automation would make sense of our course too. So maybe now let's move on to the next. So the next question is, how often do you update enter records in ERN registries? So we see that the update or entering of records in ERN registries are done mostly rarely. And a lot of participants say also never, but this could also be some of the administrative people here. And 7 say weekly, only a few say month, and actually no one enters data daily. So move on. So what resources are needed to increase participation in ERN registries would be the next question. Maybe whoever wrote CRA, could you write it out so that everyone knows the abbreviation? So we see human resources, automation, resources, a lot of resources, but also automation. Dedicated and protected time, which is basically also resources. Also IT expertise. Maybe also better communication between IT and clinician. Yeah, better communication, like someone said it also. Investment in automation, interoperability with existings. A fully registered dataset in electronic health record. Human and economics resources. Formation, expertise in registry. On-site training, also an important point. A European legal base for system integration for data sharing. I mean, this, I guess, will also come with the European health data space, which is providing the base for this. Reimbursement of activities around RD patients. Staff for ethics approval. It's also a good point. Okay. And then the last question is, how do you store data pseudonymization dictionaries for ERN registry participation if you participate in an ERN registry? So there's someone who responded, or someone who responded, they are using the local electronic health record as part of the patient records in their own center. Some say separate digital documents, for example, Excel spreadsheets. So majority is using Excel spreadsheets for now. Okay. So now we come to the next topic, which is the data sharing part and also data fairness. And I will shortly touch the data sharing part, and then we will also learn about data fairness if our colleague Cesar is with us. I haven't seen him so far, though I hope he has joined.
I'm here.
Great. Okay, so we will touch on the informed consent forms, the digitalization of informed consent, and then we will also learn more about the fairness from Cesar. And where in the data sharing part, we ask you which of the following templates you use to capture informed consent. And we see that a variety of consent forms are actually used, also dependent on the system, on the purpose. So most often, the general informed consent from the institution of the response was used, then also registry-specific informed consents with 40%, and to lower extent, adapted ERN registry informed consents, national informed consents, or generic ERN registry informed consent forms. We also saw that the informed consent is mainly captured in paper format. And as next question, we also asked if there's a section in the electronic health record that displays whether a patient has been consented or not. And we see here that it's about 50-50 that it is reported in the electronic health record system or not. So in total, we see that the many templates are used simultaneously, that the informed consent is often captured in paper format by 80%, and it's not always guaranteed that the electronic health record includes information about whether the patient consented or to which purpose the patient gave their consent. And the European Health Data Space will develop a health data EU infrastructure to facilitate cross-border data access. We think that will help to solve the problem a bit. And then we also think that a patient portal to manage the informed consent can help, and also the promotion of the implementation of FAIR principles for sharing data more efficiently will help. And now I will hand over to Cesar. No, first of all, we will do another Mentimeter before I hand over to Cesar, who will then.
Valentina, maybe we can do the Mentimeter after my presentation.
You can also do that, yes. Then I
Okay.
hand over directly to you.
I might need to leave soon, so
Yes.
okay. So
Then
let
you
me
can
share my
share the screen.
Share sound. I will share the whole screen. And you let me know when you see it.
We see it now.
Okay, good. You just have to allow something. Okay, so to give you a bit of context, I'm Cesar. I work at the Leiden University Medical Center, but in the Netherlands, but I'm Brazilian and I'm here in Brazil now for Carnival. So I decided to, do you also see the Zoom thing on top of, okay, let me see.
No, we just see your slide.
Okay, that's good. So because I'm here for Carnival, I also decided to have a more like upbeat presentation, and I will use a song from Bee Gees as a running example of this presentation. I also wanted to point out that some slides of this presentation were provided by my friend, Martijn Kersloot from Amsterdam Medical Center. So every time you see the Amsterdam Medical Center symbol on top of the slide, it means that there's a slide provided by him. When you see the JARDIN's logo, it means that it is a slide that it's just for this presentation. Next, yeah. So, well, in the previous discussions and the Mentimeters, you already had a very good idea of the impact of not having reusable data. Just to, as a reminder, we currently face several challenges in reusing data for research purposes, for example, and because it's usually hard to combine this data with other sources or to reuse it for advanced analytics, such as AI techniques. And recently, in 2019, if I'm not mistaken, the European Union estimated that the loss of money that is a result of non-reusing data, it's around 10.2 billion euros. And to cope with challenges related to data reusability, the FAIR principles were created in 2016, actually long before, but they were published in 2016, and the 4 letters are further decomposed into 15 guiding principles. And they focus on covering the data, the metadata part, and the surrounding infrastructure that supports the data and the metadata. The principles describe what you should do with the data, but they do not describe how you should do that. That's because the principles have been made implementation agnostic to respect the particularities of different communities, because different communities might choose to implement the principles in a different way. Consequently, this presentation today will focus on the what you should do, but not on the how. As I said, we have a running example, and I hope that the audio works, because I just wanted to, I assume that you all know the song, but I just wanted to play a few. I hope the audio worked. So you have the song in your head for the rest of the day now, but also this presentation. But let's say, for example, oh yeah, okay. So as I mentioned before, the FAIR principles are composed of 4 letters that mean findable, accessible, interoperable, and reusable. And I will go now to each of these letters and try to explain them using this song as an example. So the first one for findability, it says that the data sets should be described, identified, and registered or indexed in a clear and unambiguous manner. And for that, the data and metadata must be assigned a globally unique and persistent identifier, but also this metadata should extensively describe the data or the resource that you want to make fair. So to allow for this resource to be located usually using the metadata or the identifier. And also the data metadata must be included in a searchable resource. So for example, now that you have this song in your head, you want to find it to listen to it again. You might want to hear it via streaming services, for example, Spotify, Deezer, YouTube, or you can turn on the radio and hope that your favorite radio station will play the song, or you can go to a vinyl store and buy it. But let's focus on the digital part here. So for example, I will use Spotify as an example, but I will try to not mention the name a lot of times. So I'll maybe say JARDIN music. So for example, if you open Spotify and you want to play the song, as you can see, I'm in Brazil, so you see the playlist in Brazil and you see the face of the person who should have actually won the Oscar yesterday, 2 days ago. But for example, you can search it by typing Bee Gees, and you see Bee Gees, and well, at some point, if you go to the artist, you find the song. So one metadata that I used to find the song was the author. Another thing that I can do is to type "Staying Alive," which is this song title, and you also find the song. But Spotify heard the FAIR principles and decided that the metadata that they include is very extensive. So even if I typed like, well, you can see, which is I think the first part of the way. I hope it works. I use my wall. It will also show the song because this is the first lyric of the song. So you can see that maybe sometimes like you just have the chorus of the song in your head and you want to search it. It is possible because extensive metadata has been provided for the thing you're looking for. For accessibility, it says that the data sets should be accessible through a clearly defined access procedure, ideally automated, and the metadata should always remain accessible. So the sub-principles in the A say that the data and metadata can be retrieved using standardized protocol that is open, free, and universally implementable. That this protocol allows for authentication and authorization when necessary, and that the metadata remains available even if the data or the resource being described by it is not available anymore. And in our example, for example, let's focus on first on the A1, that the data and metadata is retrieved by standardized protocol. And this can happen, for example, in the JARDIN music servers, they have the song, and when you want to listen to it, it is transferred to your laptop or to your phone or to your car if it has the fancy systems via HTTP protocol, which is open because most of the internet uses it. It's free as well, and it is universally implementable. So the point of this principle actually says that if you're using something else choose something that is open, free, and universally implementable to avoid issues. For example, if you choose a proprietary protocol, and you tie it to that protocol. It also says that the protocol should allow authentication authorization. And for example, you see that most of the streaming services, they have login screen that asks you to authenticate yourself. And usually your authentication, your user is attached to, for example, to a certain plan, and this subscription, let's say, is described in the website, for example. So you have clear descriptions of, well, when I access the service, what do I have to pay or not, and what will be my access conditions to the songs, for example. And this is a principle that I would just assume that most of the services don't comply with, is that regardless the data availability, that metadata should always be accessible. This is, for example, to at least give some information why this data is not more available anymore in case of research. If you have to refer to data that existed long ago, I would assume that these services, streaming services, if they die, they would not comply with this principle because it's not on their objectives, for example. So here you can also understand that you might make some certain principles more or less flexible depending on your verification objectives. Let me go to the next slide. Interoperability, which says that data and metadata are conceptualized, expressed, and structured using common published standards. And the sub-principle says that data and metadata are described using a formal, accessible, shared, and broadly applicable representation language. That it is described using vocabularies that follow the FAIR principles, and that this data and metadata includes references to other data and metadata. So, for example, in the streaming services, they usually store the songs in their own format that facilitates their own management. But if you listen to a song in your Apple device, for example, or in your Android device, it will be converted to another format that is compatible with your device. So actually, this principle should use the plural, I would say, my opinion. Because you might want to make your data or your resource available in a few number of formats that facilitate people reusing it. Also, for the other principles, the use of vocabularies that follow FAIR and that the metadata should include references to other metadata. I'm not sure about the streaming services, but I wanted to quickly mention another example here, which is Wikidata, which is a representation of Wikipedia, and it contains information that is related to the FAIR principles. For example, if you search for BGs on Wikidata, you see that it contains a unique identifier, and it follows a structured description. So it follows a vocabulary that is FAIR, and it includes references to other metadata. I think I have more figures in this slide. For example, BGs, you have the genre, location of formation. So, and these links that you see here on Wikipedia, if, for example, hover your mouse on top of it, you see it, for example, it is a property, it has an identifier, so it follows the FAIR principles. And for example, if I click on the term discography itself, it has a description of the term itself, so in different languages even. So the metadata also has references to the metadata. And for example, in a research world, the streaming services could reuse this data easily because it is made interoperable. Finally, my favorite principle, reusability. It says that the data should be described, data in its provenance should be described in detail according to the main relevant standards with clear and accessible conditions for use. And the sub-principles says that data and metadata should be richly described. And this richly describes, for example, says that it should include accessible data usage license and detailed provenance, and it should meet domain relevant community standards. So in our streaming case example with the song, you see that, for example, some services, they have on the website description of the license. For example, can I use the stream the song in a public space or for commercial purposes? It also includes the credits of the song, so which is kind of the provenance. If you have lyrics, who provided these lyrics, and so on and so forth. So I think this is one of the last slides. So yeah, in conclusion, the FAIR principles are intended to guide you, ensuring that your data stays alive. And to conclude the presentation, just a disclaimer that this was the first time that I tried to use this example. So let me know if it worked, if it helped you understanding the FAIR principles. I'm not affiliated or sponsored by any of the services that I mentioned here, but I hope that this song and also the FAIR principles remain in your mind for a long time. And that's it. I give the floor back to Valentina.
Thank you, Cesar.
Welcome.
Very nice presentation. Then we can start now again with the, or can come now to the Menti session. Let me share my screen. Coming back to the barriers of data sharing, where we ended before Cesar's presentation, we would like to ask you how you rate the following barriers. The electronic health records may not always indicate patient consent or data reuse permissions. Also, the simultaneous usage of different informed consent forms and the capture of informed consent in paper format. So we see that the simultaneous usage of different forms are rated as the most severe barrier so far, but all are kind of similar rated around 3.5 to 4. Okay. So, and no more answers are coming in. We are moving to the next question, which is, what improvements would you like to see in year-end data sharing processes? So we're seeing uniform legal contracts, covering costs in each center, using already in place registries to able to have dedicated funding, full interoperability among registries, interoperability, uniform resource and data entry, adoption of opt-out measures while preserving privacy, harmonized data sets, common standards, a framework for fast-track approval by ethics committee. Yes, that would be great. Speak the same language as a song. So there's again a so very often financial and administrative support and interoperability. And standardization and uniformization. Yes, I think that is also what we see needs to be improved. Anything missed?
Estou aqui a responder às perguntas.
So, okay, I think there's no other answers coming in. Then I stop sharing the screen now. And I think we are at the end of our session, actually. Where's my presentation? And if you want, or if you have any questions, please.
On the chat, only that asking about the slides. Are we
Yes.
considering also sharing it with the video?
Yes, we will definitely share the video. I will ask the Shudder coordination to put it on the website, since I also got many emails that they cannot participate today due to a holiday in some countries. Yes, but if you have any other questions, Cesar, Ines, or me, you can also now speak up. So I see a question to whom the results are being reported. So it will be more an internal Shudder report, and also to feed the next steps of the projects to see which solutions we can address, which solutions are implementable, and it will be an EU report.